Welcome to the Java Cafe, Java fam. Good morning. Welcome to the Java Cafe, Java fam.
Good morning, everybody. Good morning. Good morning. Today is Tuesday, May 17th, 2022. And I've been doing pretty good with the date for the past few weeks. I think I've been doing it since we were here with Dr. Alabre last. Today is the Your Healthy Java session episode. Today is the first. Is today the first? The third. Today's the third. See, messing up with the date there somewhere. Today is the third Tuesday of the month. And as we do every first and third Tuesday through the support and partnership with the Massachusetts General Hospital Office of Equity and Community Health, we come, and as your community-driven platform, we're also on the first and third Tuesdays, your community health platform. And so through that partnership, we've been able to share a lot of information around a lot of topics. Today's topic was actually planned before a trending topic as it relates to women's health started about a week and a half or almost 2 weeks ago. And so we have some topics we're going to talk about that may be related to that topic. And I'm not saying the topic, but you know what I'm talking about. But we're going to talk about breast cancer, cervical cancer. We're going to talk about routine and preventative health care, maybe get into alopecia and hair loss that doesn't just impact women. And let me also say this session is not just for women. If you are a man and you love a woman, a daughter, a spouse, a sister, a cousin, a godmother, a coworker, or a friend, definitely listen in. And go ahead, everyone, and do me a favor real quick. Just hit that share button so we can get this information out to the community as greatly as possible. And so without further ado, because we're still dealing with COVID-19, Dr. Alabre, our medical director, is going to come in and give us sort of a COVID-19 update, vaccination. And Dr. Alabre, how art thou, sir?
Hi there. I am doing well. Thank you. How are you?
I am doing well. I'm kind of excited. We had our little.
You look it.
Y'all, if you don't know Dr. Alabre and I's cadence or how we flow, it's just awesome. And he's picking up some things in the Java Cafe. But Dr. Alabre, how are you? How are you doing?
I'm doing well, really.
That is good. That is good. So we're still dealing with COVID. There are new variants. I seen an article the other day talking about the BA 2.12.1. Then we got the B2 and B. What's going on with COVID?
You're keeping up.
Yes, I am.
Yeah, I mean, basically, the virus is still around. That's really the best way to summarize it. It's still there, and unfortunately, we are seeing, as you mentioned earlier, an increase in cases. And we're also, unfortunately, seeing some increase in deaths nationwide from COVID. And so that's not the best news we have. It's still better, obviously, than last year, than the year before, but there has been an uptick. And I know we sort of mentioned this last time we were here 2 weeks ago. And some of the factors, some of the parameters we're looking at is sort of the wastewater count of the virus and the cases and hospitalizations. And unfortunately, all three are up for the past 14 days. That just ended on Friday. We did see a slight decrease in new cases. Again, it's a little bit confounded because people are testing at home, not everyone's reporting it. And so the message I have today is really to make sure that people are still taking this seriously and doing the best that you can to keep yourself safe and prevent sort of severe diseases and deaths. Obviously, it's very concerning. And the best way to do that still is to get yourself vaccinated. If you haven't done it, get yourself boosted if you haven't done it. And if you are eligible, 50 or older, get your second booster, and especially if you have comorbidities, which is sort of risk that would put you at a higher risk of severe illnesses. We've got, asthma, diabetes, obesity. There's a few things. So do your part, get vaccinated. Don't take the chance. It's just not worth it. And then the second part I wanted to sort of bring up is that if you are testing at home and you are positive, reach out to your doctors, because we do have the antiviral pill, Paxlovid, a lot of people have heard about it, that can further reduce your risk of hospitalization, severe illness, and deaths. And so you don't have to know whether you qualify or not. Just reach out and find out if you do qualify for it. Not everyone does, but actually a lot of people do, and not everyone is getting it. So I want to get the words out that we do have one more thing in our sort of toolbox besides the vaccine. And so get your pill. And another thing I think just happened yesterday, or maybe today, the government is sending out more free testing kits.
Yes.
And so go to covid.gov, covid.gov. It's really simple. I did it myself this morning. Quick, put your name, address, and that's it. You hit enter, and you should be getting it through the USPS service. And I think they've increased the number of kits you can get this time. You can get up to 16 tests per resident. And so do that, because it helps you know if you feel unwell or if you have any questions, exposure, get yourself tested. That way you can protect your loved ones, people you live with, and then you also can take the steps that you need to take to protect yourself, because the pill, you should be doing it within a certain number of days, ideally within 5 days of testing positive or symptoms. And so don't delay it, just reach out.
Okay.
That's all.
Dr. Alabre, thank you for that update, because one of the things that we started out with the platform in Your Healthy Java is the availability of ready information in reference to COVID or other information. So I'm going to be honest, some of you all know I switched the aesthetics in the background here because today is Your Healthy Java. And so just want to acknowledge that. As we're getting ready to bring our guests in the room, as I said before, we had this topic planned. We planned these out at least a month, to 6 weeks before, Dr. Alabre. And so I just want to get ready to bring in our guest, Dr. Qureshi. She's going to come in and speak with us about women's health. And Dr. Alabre, I'm always sensitive to, when we have male and female balance. So I'm going to take you out for 1 second, bring Dr. Qureshi in so she can be on top, and we'll be all set here as far as appearance on the screen. So we're about to bring her in. Give us 2 seconds. Dr. Qureshi, welcome to Your Healthy Java. Welcome, welcome. You all don't know that sometimes folks sign in a few minutes early. And at first impression with Dr. Qureshi, I got kind of excited. Dr. Alabre said, yeah, I can see that. And so as we say here often, it may be a couple of those uh-oh moments, but Dr. Qureshi, say hello to everyone as I do with Dr. Alabre and our guest. You guys in the medical world, first responders, have been dealing with a lot. And so with your introduction, please let us know how you are doing beyond what you provide to the community in the service. You as a person, how are you doing?
Oh, good morning, Jimmy, and thank you for having me. And thanks for asking that. I'm actually doing well. The work is hard, but it's meaningful. And just as Dr. Alabre mentioned, yes, please call when you get COVID, and we'll talk about the medications and for all other health issues. It's busy, but really meaningful work. Thank you.
Absolutely. Thank you for answering that. And tell us a little bit about yourself. And then we'll go right into the questions, because we want to take advantage of your time. And Dr. Alabre can give some context as well about why we're talking about this subject.
Great. I'm a primary care physician at Mass General, a colleague of Dr. Alabre's, and I did a women's health fellowship in the 1990s and have worked in Cleveland, where I did my fellowship, then in Brockton and Braintree, and now in Boston. So mid-career physician, and I'm a primary care physician, so I love everything. But women's health is still, women come to me, and I take care of whoever comes.
Absolutely.
And learn more about it. So thank you.
Absolutely. And it's so important, Dr. Labrie, we can, talk about why we talked about this, because we have talked about women's health before, women's heart health, but we're talking about women's health in general. And so, Dr. Labrie, with you being a primary physician as well, why do you think it was important to talk about? As I said, we had this subject planned a few weeks ago.
Yeah, I mean, a part of the biggest driver, I think, was to commemorate sort of Mother's Day, Day,
Yes.
Women. So we wanted to have a little bit of time, especially for sort of the health concerns that are particularly important for women. As you said, it's really everyone's health, but this is just giving us the opportunity to take a pause and break and make this really something special.
Absolutely. And so we're a little bit behind because we are only on first and third Tuesdays, but let's just jump right in. Dr. Qureshi, as someone who is past the trainee stage and have been in primary care for a while and who is a woman, how would you describe the status of women's health in one word?
Oh my, OMG.
Wait. Okay. Well, I guess that. Wow. Okay. I don't get stumped often, but okay. So OMG, but what makes you, in all seriousness, what makes you say that?
So I guess, the elephant in the room is the Roe v. Wade Supreme Court decision, which is, it's leaked, but I think it is. So hence the OMG.
Yeah. Okay.
Because and there's been a lot of great, changes and advances for women. This just kind of is the OMG moment, because it's not just, it's not, regardless of what your thoughts and feelings and beliefs are about abortion, it's really about, this decision is about removing women's own advocacy and agency over their own bodies. So hence the OMG.
Absolutely. And I just wanted to say, in all fairness to us, and some people may know my opinions, but what we're talking about today, two things I wanted to make sure you as the audience know. One, both of these doctors have not had the opportunity to examine you. And so any information or general knowledge that they share is sort of general. The best thing that you can always do is reach out to your primary care physician if you do not have one. What's the number to call real quick, Dr. Alabre, for new patients?
Ooh, you stopped me on that one.
Okay. We'll put it in the private chat when you get it, and we'll put it up. But the other disclaimer we wanted to mention as well is that we are sharing medical information, but also anything that may come out around our personal experience in reference to, and Dr. Qureshi said it, I was dancing around it, but Roe v. Wade. These are our opinions as James, as Claude, and as Dr. Qureshi. And so women's health is I mean, that is a trending topic there, but there are other things that Dr. Qureshi, I'm sure you see in reference to women's health. Where are we in women's health besides Roe v. Wade? What are some other the concerns, advances, however you want to update us? What are some of the things you wanted to share with us this morning?
Thank you. Yes, a lot of good things are happening in medicine for women, and medicine follows what is happening in society. So not to beat up on the patriarchy, because Jimmy and Dr. Labrie are allies here. So I'm teasing you, but society is still for male dominated or male centric. So even with 51% of the population, so what happens in the workforce, or lack of maternity leave and such, really does, and high maternal mortality rates, all of these things do make a difference to health for women. That said, from in the 90s when I did my women's health fellowship, there have been a lot of advances in heart health. I know Dr. DeFaria spoke about that as well. And so that's really in part of what we do whenever we're assessing a woman who might have heart disease. So as far as other, I mean, certainly reaching out, there's huge advances in women's health and cancer and contraception, menopause. So I know we're going to talk about some of these things.
Absolutely. And just wanted to let everybody know, please remember, and I thought I typed it here. We are going to take your questions toward the end of the session here. And so, Dr. Qureshi, what is let's start maybe with a concern and we'll end maybe with advances. What's one of the number one concerns for you, especially when it comes to women of color, Black women, when you're looking at, and I know we have our wonderful academic physicians, and so they look at data, which we've learned over the past couple of years is hugely important. What is some of or one of your number one concerns as it relates to what you're seeing in the data?
So and this is looking at cancer deaths. I mean, heart disease is still the number one cause of death for white women and Black women, but cancer is the number one for brown women and Native American women. So, but when it comes to cancer, Black women for all cancers have an 8% higher chance of having, lower rate of cancer, but actually a 12% higher rate of mortality. In other words, Black women get fewer cancers compared to white women, but they die more. Yeah.
It's doctor.
Go ahead.
See, there's one of those moments, and so you can't help but hear inequity there.
Yeah.
Because though we get it at a lower rate, we're dying more. When I say us, I mean Black and brown.
Yeah.
And so, okay, I'll make a note and hold that moment for later.
And it's when you look at the data, it's intriguing but also worrying because there's a lot more studies that need to happen, and actually these studies have been happening for decades now to see why. That disparity in mortality, in other words, Black women dying more, happens at even early stage detection of cancers. So whether it's, we at some stage we're thinking, well, maybe it's Black women present later, and so that's why, but it turns out even for early cancers, the mortality is higher. And a lot of what we know is that we don't know. So, studies are still going on. That actually does then remind me to say that if you're Black or brown, make sure that you do get your breast cancer screening sooner rather than later.
And some of, if I'm familiar enough, I believe some of the criteria over the past couple of years has changed. Let's just say we don't know if that was informed by insurance or not.
It wasn't.
Oh, okay. I love you. Okay. And so what is the standing for women to get their breast exam?
So certainly there are no studies the studies haven't really shown that checking your own breasts help, but I actually think it's a good idea for women to check their breasts regularly. Yes. So women who are having their periods can have normal lumpiness just before the period. So, checking after the period is a good idea. But the standard right now is really mammograms. And the clinical breast exam. So, having a primary care physician or nurse practitioner, physician assistant who does the breast exam every year, or GYN, but the mammograms really have become much better. It's a much lower dose radiation. Technically, it's a much better test than before. And the recommendation is actually based on data. So the United States Preventive Task Force comes up with the recommendations. So we usually say the first mammogram at age 40. Okay. Yeah. And a mammogram will prevent death from breast cancer 15 years from when it's done. So, if you're 80 years old and you're healthy and everyone in your family lived to 95, then get your mammogram. And if you feel, let's say you're 80 and you don't have that much your longevity, then it might not be as helpful. But really the time that it's most helpful, the mammograms are 40 and over. The recommendations are actually vary. So it could be every 2 years. Insurance will actually pay for it every year. And I don't know what Dr. Labre feels, but I actually say every year is good, is best.
Dr. Labre?
I do mostly the same. Yeah,
Yeah.
there is some variability with the data in terms of starting at 40 versus 50 every 2 years or every year. And this is part of what's becoming how we practice medicine these days, with shared decision making, because there are some nuances, there is some variability. We're not at the point where we can do individualized medicine yet. So to really know someone's particular risk and who should do that, so we cannot present the information that we do have, the data, to the best of our abilities, instead of decide with the patient. Again, that's the part where we can't tell you, but we can encourage you to have the discussion with your doctor instead of make that decision for yourself. But the range is 40 to 50 to start, and then every year to 2 years, depending.
I just wanted to mention a message that I'm hearing from both of you, and it's something that we know when we talk about routine and preventative healthcare. But between the two of you, I've heard check with your primary doctor at least 4 or 5 times this morning. And so I have to center that for everybody that's watching, that no matter what we discuss and come up, your number one resource for you to check in with is your primary doctor, because presumably there's a relationship there. Dr. Qureshi, anything else around the breast cancer piece?
I think actually, for primary prevention, which is how not to get breast cancer in the first place. So the risks are things like and things that you can't always control, genetics, and if there's a family history, get checked for cancer genes, but also lifestyle things like keeping the BMI low. Exercise helps. Alcohol, even just 1 drink a week, 1 drink a day, is a risk factor for breast cancer. And if it's possible, having children before the age of 30 and breastfeeding is protective, but not certainly as much as the other lifestyle changes mentioned.
Okay. Dr. Qureshi, thank you for that. I know because of my time as a youth worker, I used to work when the young ladies would have pap smears, and they would come and they would need to get
colposcopies.
Yes, not colonoscopy. And so part of my assignment was I needed to go chase them to get them to come back, because at worst, that untreated develops into what? Or could possibly develop into what?
Cervical cancer.
Cervical cancer. And so is that another concern as far as the stats and numbers with you as well?
It is. And actually, this is an area of huge progress where, the cervical cancer cases have gone down. And I was looking at the kind of estimated numbers for 2020. So cervical cancers, they're thinking there'll probably be about 14,000 new cases, but only 4,000 new deaths. Compared to ovarian cancer, it's probably estimated 20,000 new cases and 12,000 new deaths. So, a lot of women who even do end up getting cervical cancers do well. And the early detection with pap smears has really revolutionized that. The other part is also the HPV vaccine. So we know that human papillomavirus is a virus that infects men and women.
Yes. Yep.
It is actually, so the higher, there are some that cause genital warts, but the strains that do cause cervical cancer or abnormalities can end up causing or leading to cervical cancer.
Okay. And so again, I heard, and Dr. Alabre shares this often, is that prevention and screening. So I'm getting this right now as we talk, that 2 of the most paramount things you can do around your healthcare is keep up with your routine and preventative healthcare. And often those include, age, gender screenings.
Yeah.
Am I right there, Dr. Alabre?
That's absolutely correct. And I'll just add one more thing to what Dr. Qureshi just mentioned, is that the HPV vaccine is now being used routinely for 11, 12-year-olds, but it wasn't the case about 16 years ago. And it was not as routine for young girls. And the good news is that insurance companies had stopped paying for it after age 26. That's no longer the case. Now you can get it covered until 46. So if you are 32 and older, chances are you did not get it when you were preteen. And so you can now get it, and it's paid for. and the risk, as Dr. Qureshi mentioned, for cervical cancer is pretty significant, and it can really reduce that by just getting a simple vaccine. Again, we're sort of talking about vaccines again. This is really made a huge difference in mortality for people. And so both men and women, if you are eligible under the age of 46, you can get this, even if you pass the old age of 26.
Yeah. And isn't it as amazing that a vaccine can prevent cancer? It's apart from cervical cancer, and it's as Dr. Larbry mentioned, it's boys and girls who receive the vaccine, and the other cancers it can prevent are head and neck cancers, penile cancers, cervical, as we mentioned. There is one. Oh, right, yes, anal rectal cancer.
We are definitely a team here working together. So I just wanted to make sure that we capture that folks know that both men and women can get the HPV vaccine up until age 46. I didn't know that, Dr. Larbry. When I was a youth worker, it was just like that was part of the work of figuring out, getting the information out. You said what, 16? Okay, time flies. And so did we get, and I know we can't get everything, Dr. Qureshi, but we covered breast cancer, cervical cancer. We had also mentioned that we may just talk a little bit because I know that unfortunately trending, there was the whole issue with Will Smith and Chris Rock. There was a lot of conversation, and we got to also, since Congresswoman Ayanna Pressley revealed that she is dealing with hair loss is something, and let's just be real. I grew up in a house with Black women. Hair is it's more than just the appearance. Hair, a lot of it can, for some, it can influence mental health. And so we're going to talk a little bit about that today. Where are we with hair loss and either prevention or maybe some treatments or things? Because we haven't really talked about that a lot. And it is something important to women.
Yeah, thank you for bringing that up, because it's the hair and our skin shows how we are healthy, or our health on the inside as well. So and I'm so glad Ayanna Pressley shows her beautiful head with pride. And just as an aside, actually, I think the SLAP, as it's called now, is actually trauma response. So that's a trauma-informed care is a totally different topic.
That's almost a moment, because that's my wheelhouse, Dr. Qureshi. So
okay,
that's definitely something that we could maybe have you back and talk about, because that you're on it right there. Yes, ma'am.
So but back to alopecia, which basically just means hair loss. So for women as well, it's their crowning glory, and it's also what people see. So but there are I think, again, coming to primary prevention, which is how to take care of your hair in the first place, is taking care of your health. And one of the most common causes of hair loss is telogen effluvium, which is just a fancy way of saying that when there's stress to the body, hair will fall out. And usually it's a 3-month, so the hair does have a 3-month cycle. So if something happens now, let's say to me, it'll be 3 months from now that my hair will fall out. So we actually did see this with COVID. So in 2020, when everyone was totally stressed out, by June, there were in the Boston area or New England, lots of people were calling with their hair loss. There was actually New York Times article on that as well. So March, the trauma happened. Yep. June, everyone lost their hair, and then by September, it's growing back again. And
let's just name Dr. Qureshi part of that now, in all seriousness, but we practice Black joy here, so folks may get a snicker out of this. Part of that was also the fact that the brothers and sisters couldn't go get their hair did.
Oh, yes.
I just saw a video from like 2 years ago, and I looked like Wolverine. And so, but valid of what you're saying, but I just had to throw that little joke in, because we are talking about something so serious. And while, if you let me interject, so the appearance can have an influence on mental health. But from what you just said, our mental health obviously has an influence on our appearance. I never knew the piece about the 3 months. You would think that it's in the moment, like a stressful situation happens 2 weeks ago, and you're going to see, breakage and hair loss in 2 weeks. You're saying it's like a 3-month cycle before you see that. That's interesting.
It is. And usually when someone says, you know what, September of 2021 is when I started losing my hair, then we usually know, okay, so what happened in June? And they're like, oh yeah, I had the surgery. And so that usually goes along with the telogen effluvium. And the good part of that is that it will grow back. And the time to get concerned is that when, men or women, if they say that it's patchy or there's itching, or, then that's more of the scarring part. And also if it's kind of gradually being, losing hair, then seeing a hair dermatologist is a good idea. And there are at this stage, because again, there's been that discrepancy or for a while that, a lot of what's known in dermatology is according to what white skin and white hair looks like. And so there is better education now in dermatology on.
Absolutely. And Dr. Labrie, anything else there to add?
Not really. I think the big thing again is check with your doctors, because there's a lot of different conditions and reasons, as Dr. Qureshi just mentioned. She gave one example, a couple more, but there are cases where it can be because of a thyroid issue. It can be because, as she mentioned, inflammation that can actually require an intervention. There are injections that can be done in the scalp to reduce the inflammation and resolve that issue. The other big thing is that you mentioned, you're now understanding a little bit better about the difference between part of the
Hold on, go ahead, Dr. Labrie. We're gonna hold it here. Hold on. Go ahead, you're good.
There we go. And so one of the things we are understanding now is the impact of certain hair treatment. Extensions, different hair products, straighteners can have on hair later on. So it's really good to have a consultation if you are experiencing this problem instead of decide, or even probably before you start doing certain things with your hair, it might be a good idea to run it by your doctors and think about what the impact may be for you down the line, so that you do this appropriately. Because doing it wrong in your 20s can actually lead to what we call scarring alopecia, which is not really treated well at this point down the line. So you may be seeing something in your 40s because of what you may have done to your hair in your 20s. So be careful, check with your doctors, and think about the things that you need. And we understand, obviously, these things are important. Some of it is cultural, but there may be ways to mitigate the impact.
Some of the cultural piece, and I'm just going to say, without the medical advice, I remember aunts and mothers and sisters and whatnot. Girl, you better stop, putting all that weight and pulling your hair and keep it. So there's the medical aspect and there's the cultural aspect as well. Dr. Qureshi, we're going to start taking questions in a few moments.
Sure.
But can you just define for us, because as Dr. Labrie just said, there are different types or conditions that can lead to hair loss. But when Congresswoman Presley came out, also, the SLAP, that trauma-informed response, alopecia was the number one topic. So in layman's terms, what is alopecia?
So alopecia is, it's from the Greek for wolf.
Yes.
for wolf, and from the mange that wolves get and losing their fur. But alopecia is actually more, it's a symptom. It just means hair loss.
Yep.
Whereas, as we've discussed, that there are many different causes for it. So if you are losing your hair, check into why it could be, and there are treatments. So there are hormone testing, mostly the thyroid. Genetics plays a large part too. So if you look at the men in my family, they all pretty much lose all their hair by 30, and the women sometimes. But and
can I ask you a question? Because there's this urban legend. I don't know if it's true or not, but I remember growing up hearing that you get the hair gene from the dad. Is that okay? Because I remember growing up hearing that, and I'm like, okay, so that's interesting. So if you're a daughter and your dad is, bald at 40, are you walking around stressed out because you think? I'm telling you that there's some myths and stuff, not just during COVID.
Yes.
Dr. Labrie talking about culture. There's some things in various cultures that we need to make sure we have, the right information. But I really did want to ask that. Anything else with alopecia before we start taking some questions?
No, really, I think mostly that there are treatments, and minoxidil over the counter is something that anyone can use. If it's not working, then you know that it's not something responsive to minoxidil, so it's a good idea to get checked. But for people who are thinning, the male pattern, which is that receding shoreline or hairline, and for women as well. Yeah, the baseball caps do not get rid of hair, so baseball caps are fine.
Wait, because that's another urban.
It is, yes, unless your ponytail is really tight.
So that's another. Oh, Doctor, see.
No, the ponytail, if it's really tight, or your braids
are follicles.
Exactly, and your braids are too heavy or tight, they will pull on it, and once you get rid of them, it'll grow back. But your baseball cap won't make you bald.
Okay, one last final hood legend question. I don't know if you know this or not, but here's another one.
Yeah.
Dirt makes the hair grow. Have you heard that one? Dirt and oil.
I haven't.
Okay, I heard that one.
I'm South Asian, so it's coconut oil and sesame oil and all this oil in the hair in order to help it grow.
You just got a free nugget there, y'all. Coconut oil is.
But it doesn't particularly work. It just gives it some shine.
Wait a minute. Dr. Qureshi, I thought we were giving out some nuggets there. Okay. Thank you for your honesty. Let's go in and ask some questions back to Pap smear. I mentioned to you we have the mother's board, and sister, we put Sister Debbie in that, and she may get me for it later. But do women over 65 still need to get a Pap smear?
That is an excellent question. In fact, 65 is usually the cutoff for when we stop doing Pap smears, and this is a good opportunity to go over the schedule. So, we start Pap smears later than we used to. So we used to start them at 18 or whenever a woman was sexually active, but now we start later at 21. And the story is that HPV, wherever HPV goes, cervical cancer goes. So when a woman is initially sexually active, or I should say any person with a cervix is initially sexually active, then they can be infected with HPV. The HPV can either, the body says, oh, I'm getting rid of this with the immune system, or especially if they've already had the vaccine, the immunity is there, it says out you go and they're fine. Or the HPV just kind of sits around in the cervical cells, and then it can start causing trouble down the line. So that's why we start at 21, and that's really assuming that a woman has been sexually active. So if a woman or a person with a cervix has not been sexually active, then we actually don't need to start it at 21, although that's kind of the art of medicine and talking to your patient
and having that relationship. And so if I understood you correctly, if they start sexual activity either by choice or by circumstance at a younger age, is that when you start talking with your physician about a Pap smear rather than waiting until 21?
Yes.
Okay.
You start talking anyway, ideally before any sexual activity, so that so we can talk about what consent really looks like, and then later on, okay, I got the look, what does that mean?
No, Dr. Qureshi, you called me out. No, it's just that I like the piece that you're sharing so much here. I like the piece about you're basically training and informing consent at an early age. And so as a former youth worker, that stood out to me.
Oh, okay. Thank you. And so and then coming to Deborah's question. So, we check for HPV at age 30. So we do the Pap smears from 21 to 30, looking for abnormal cells. And then from 30 onwards, we check for HPV. So we wait till 30, basically because the body has either gotten rid of HPV by now or it hasn't. And so at 30, if HPV is present, then we actually check the PAP and HPV together every year. So it's fairly binary. So either you're at high risk or low risk at that stage. So if HPV is present, then you're at higher risk. So we check HPV and PAP every year. And if HPV is not present, then you're at low risk, in which case we check every 5 years.
Okay.
And so by age 65, if your pap smears have been normal and you've remained negative HPV for at least 10 years, then we can actually stop them.
Okay. Thank you so much. So hopefully, Sister Debbie, that question was answered.
Debbie, too, part of the reason we stop at 65 as well is because the tissue in the cervix that can actually acquire the virus, the HPV, and turn into cancer actually recedes. It gets, you don't have it anymore. So I know I get a lot of patients who are really nervous about stopping because obviously cancer is a big deal. No one wants to get that. And so to say that we can stop now, and they wonder, what, are you giving up on me? Like, do you think I can just get cancer? It doesn't matter. But the reason is not so much that it doesn't matter. It's really primarily because you don't have the tissue in the cervix anymore to lead to that cancer. So it's okay to stop.
Okay. And again,
and it is a
go ahead. Sorry.
And it is a conversation again, because in women in menopause, we will give vaginal estrogen to help with vaginal dryness. And I'm thinking of a patient of mine actually who was widowed for a long time and had a new partner at age around 65. And we said, well, you could have HPV now from a new partner. And we checked and there was HPV. So it's, thankfully she did well. But so on a person to person basis, but most people with a cervix at age 65 have had the same partner.
That just made me think about some years ago. When the little blue pill and others became popular, there was unfortunately a spike in STIs and STDs in senior citizens, and that it is not funny, but it just when you said that, I thought about that. Brother, one of our brothers has a question, and we're going to ask that at the end since we're centering around women's health. But Naraki is asking, do you believe that there should be some type of physical therapy prescribed to those who have had hysterectomies, whether total or partial? Wouldn't it help with strengthening the pelvic floor after surgery, or even bladder therapy to strengthen that as well? Good question there. I mean, these are the physicians, but good question.
It's an amazing question, actually. It's almost like you read my mind. You know all my the things I'm passionate about. So pelvic PT is something very important, and I would add to that actually doing strengthening pelvic floor after delivery. Even in pregnancy, for prenatal yoga does some of that. But I do agree that, because with hysterectomies. It's also not just the removal of the uterus, but it's also the reason why. If it was a large uterus because of fibroids, there's usually pelvic floor muscle and tissue changes that have happened. So yes, I think and part of the pelvic physical therapy is really knowing. If the pelvic my hand. So the pelvic floor goes from the pubic bone all the way back to the coccyx or the tailbone, and there can be times where the pelvic floor is very tight around the back part and loose at the front. So the bladder is leaking, but there's constipation. So pelvic physical therapy is a very specific type of physical therapy where there's an internal exam. The therapists have been trained specifically. So saying just do Kegels doesn't really help, because it's you don't want to tighten the whole muscle. You want to maybe stretch a certain part, strengthen another part.
Absolutely. It's I think it's just amazing that I keep hearing this. I'm inclined to say, if you're scheduled for this surgery, or if you're dealing with any issues, talk to your primary care physician. And then if you're moving in, I believe that this would probably be with the obstetrics is the pregnancy, GYN. The gynecologist would be the doctor that you would talk about with this, and making sure that pre-op you've talked about, hey, I want to get a referral or whatever around pelvic physical therapy.
And actually, I would put a plug in for midwives, because the midwives actually are the ones who I delivered with a midwife and an OB who did my emergency C-section. But but I remember my but I remember my OB even saying that he learned so much from the midwives, and his episiotomy rate went down because of all the different techniques they taught him to teach the patients. So then the midwives do a lot more on how to take care of the pelvic floor, and OBs do as well. And so, doulas and other, usually women who help around pregnancy can help too.
Thank you. And that's something I've seen with a state representative, Liz Miranda, Ayanna Presley. They've all talked about it as well, about midwifery, if I'm saying that right. And so for those of you that don't know, I can flex a little bit of my medical experience. And episiotomy is basically the process in which they cut, if I'm right, they cut the vagina for delivery, or I may not have the exact part in the vagina, but rather than being ripped, they cut it so it's an easier incision in case that has to happen. Am I correct there?
That's right. So it's the perineum, so the area between the vagina that goes back towards the anus and rectum.
Yeah. All right, Dr. Labre, see, I know a little something, sir. One of the things that and my mother, it's so funny because when folks try to get my attention and they don't, my mother sees, and then she's now talking about, can you talk a little bit about men and breast cancer? And I believe it's my biological granddad that she's just sharing with me now, that had breast cancer as well. And so can we talk a little bit? This was centered around women. And so I was very deliberate in waiting until we talk about the testosterone carriers. But in all seriousness, Stan is asking, and I believe the proper term that Stan used is gynecomastia.
Yes. So gynecomastia is the growth of breast tissue in men. And men have nipples. There's breast tissue in the area, but most of the time it doesn't really grow. Now, fat tissue, we think of fat as just padding, but it does actually convert estrogen to testosterone and testosterone to estrogen. So in men who have a high BMI, in other words, who have a lot more fat tissue, they often will have breast tissue, a little bit, and that's because their testosterone is being converted to estrogen.
Wait. There's a whole lot there to unpack.
Yes.
So if I heard you correctly, that a cis-identifying male, if they have a lot of fatty tissue, that part of that processing or somewhere that fatty tissue where we're prone to have more testosterone, fatty tissue can almost convert it to estrogen?
It's a little simplistic, but yes.
Okay.
I mean, simplistic the way I said it.
Okay.
So there are other medications that can cause gynecomastia. Spironolactone is a big one. It's used for acne and for other conditions. Things like liver failure can also cause gynecomastia. So just that presence of breast tissue. The other big thing that can cause gynecomastia, and I've seen this in my patients, is, or actually two things, is external hormones. So men who do a lot of weightlifting, who take all kinds of supplements that actually have testosterone and other hormones in it, can cause breast tissue to grow. And the other is with chicken, especially, that has a lot of poultry is grown with lots of estrogen. So another patient of mine I'm thinking of, he actually had breast tissue on his he had, ripped muscles everywhere, but he ate a ton of chicken, and that's where he got it. And when we just said, okay, go organic for the chicken, it actually did recede. I know it's just one patient, but.
No, because the only reason why I had to snicker is because within our culture, there's presumptions, non people of color, make jokes or whatever. But we're known to, culturally speaking, Black folks, Black Americans are known to eat a lot of chicken, and then fried doesn't help. And so with you saying that was an interesting data point. That regular fatty non-lean chicken could, it has estrogen in it, and it could lead to some things for the brothers. That's interesting.
Oh, I don't want to. I don't want to beat up on fried chicken.
No.
But-
Listen, you can, but you know, we'll still consume it. But it's all information. I think like this is we talk about healthy lifestyles. Hearing that little, you know, short, uninformed synopsis of mine might just help somebody. Maybe, you know, once or twice a week that may eat chicken 5 times a week. They may cut to 3. It may not directly benefit what we were just talking about, but overall, it's definitely going to help their health. Agreed?
Yeah, and actually, I mean, certainly, when we look at breast cancer, and I mean, certainly much higher in women, cutting down meat of all sorts, animal fat helps.
Okay, absolutely. We have one more question here. Can you talk about endometriosis, which is the swelling of the uterine line?
It's
No.
it's a specific condition.
Dr.
It's a specific condition, endometriosis. What is it, and how do we treat it? Oh, you had. Sorry to hear that, stage 4, and didn't know. So endometriosis is ectopic endometrial tissue found in different places, usually in the pelvic area, on you know, anywhere where it shouldn't be, which is the lining of the uterus. Sometimes it can be in the muscle of the uterus, and sometimes in the gut as well. But the key to it is that there's extreme pain, or a lot of pain with menstruation, and depending on where it is you know, is how it's treated. So and stage 4, that can be tough because some women will have endometriosis, and the staging is according to where it is. In the body, usually in the pelvis. So it's very severe menstrual cramping that happens. For some women, it's cramping in other parts of their, you know, belly and the pelvic area. And so the way to diagnose is certainly clinical, as in knowing that this is how it presents. And the other part is with a laparoscopy, which is it's usually a gynecologist. So they put a little hole. It's a surgery, so under general anesthesia, making a little hole at the belly button, looking with a tube, and literally actually looking into the pelvis, and they'll see little splots of endometrial tissue or endometriosis. And so the kind of treatment, so when that is, by the time you need a laparoscopy, symptoms are usually pretty bad. And so the gynecologist will buzz those. I'm not a gynecological surgeon, but this is kind of the general part.
And that's what we do. Yes.
Yeah. But even before that, actually, because the pain is with menstruation, a lot of times treatment is by basically suppressing the menses, and that can be done with a hormonal IUD with progesterone, because progesterone will help to shrink that the lining of the uterus. So even if contraception is not needed, the progesterone IUD will be helpful. And then also birth control pills, so that with estrogen and progesterone, but given continuously. So, and that can be used for contraception as well, but certainly, you know, about 15 to 20% of birth control prescriptions are for non-contraceptive use. So for endometriosis, your physician would, or OBGYN would give it to you so that you take it, you know, all month long, all year long if needed, and that's safe to do. So basically suppressing the menses. Some women will, you know, say, okay, I'll take a week off and have a period, but then with endometriosis, you'd have a lot of cramping, so we wouldn't recommend that.
Okay. Dr. Qureshi, thank you so much for everything that was shared today. There was a lot of information, and I believe Dr. Alabre would agree. You know, as a man, we need to be familiar as well. And I just also wanted to highlight your sensitivity and the fact that we were talking about the cervix, that you said that individuals who have a cervix and not just women. And so I know that that's another topic as well that you know is coming up. But thank you for your sensitivity to our trans women population, or in that case, trans men, or whichever. Thank you so much for being sensitive to that there. Dr. Alabre, anything that you would like to share before we have Dr. Qureshi give her closing remarks?
Yeah, actually, I just put up the number for their physician.
I have it. I was going to show that toward the end, so I got that covered.
want to get their doctors, you really should. I mean, if there's one message out of this whole program is that get back in touch with your healthcare providers and really take care of your health, basically. And so this is one of the numbers we've talked about. There are lots of different ways to get your care, so whatever works for you. But obviously,
what is this? What is this saying, Dr. Alabre?
Healthcare matters. Get it where you can. No, in all seriousness, we know there is a shortage of primary care physician in a lot of places, and so there are people who are waiting months and months to get doctors. So I cannot make you a promise that if you call this number, you'll get a PCP today, but at least you can get on the wait list or whatever it takes. But also there are other community care providers and other hospitals in the greater Boston area that are doing a great job, and there's no reason not to get your care if that's where you are and that's what you can access. But we don't want access to be the reason you end up with severe diseases, cancers, dying, and all other kinds of complications.
Dr. Alabre, as always, thank you. Dr. Qureshi, your closing remarks before I go and do some announcements after you guys exit. What would you say to the women out there who, generally speaking, are their healthcare is really on their mind right now? And we didn't even really get into the mental health piece and so, but what is it that you would say to women in reference to their healthcare and maybe some concerns they have in general?
Yeah, I would say, your health is in your own hands to start. So for women, and women tend to be caregivers as well for elderly and for children. So, we think of the care of others is in our hands, but remembering to take care of our own health first. And I know I'm saying this and I'm not always practicing what I preach, but take care of your own health and both for men and women and children. And I shouldn't be so binary about genders. But remembering that, if you are concerned about something, then it's real, and finding out about it in any way you can with, trusted people. Dr. Google isn't always the best, but it can sometimes be a start. And then finding, I'm certainly a proponent of the physician doctor patient relationship, or actually certainly nurse practitioners, PAs as well.
Yes.
But empowering yourself, and knowledge is power.
And that's one of the reasons why we're here. And I'm so thankful for this partnership with Massachusetts General Hospital Office of Equity and Community Health. Don't forget, and I'm pointing on the screen like y'all can see the cursor, but the physician referral line at MGH is 1-800-711-4644. If you do not have a primary care physician, maybe want to look at another one, because it is important that you feel comfortable and have a good communicative relationship with, or communicate well, rather, I can make up words, communicate well with your physician. And so I worked at MGH and I know some of the physicians, and these are two of them there. And one of them is committed to being with us twice a month and does a lot of work around the background. And then this other one today was just so amazing with just everything that was shared. And the comments are here. Thank you so much for your time and information. Great information. Yes, thank you for so much information, doctors. And so thank you so much, Dr. Qureshi and Dr. Alabre. I will be in touch, sir. And I believe our next session, I don't have the thing opened up in front of me, Dr. Alabre. What are we doing for
health?
We're doing men's health. We're doing men's health, getting ready for Father's Day. And then also in June, we're going to do a session in support of, or just looking at some things in reference to the LGBTQ plus community. And so June, we have some great things coming up for you. And yes, thank you both for being here today. And Dr. Alabre, I will be in touch. Dr. Qureshi, I'm sure that Dr. Alabre will tell you soon that Jimmy has requested you come back. And so, you know what, Dr. Alabre, if we got her and Dr. Ronke, oh my goodness, I'd be up under this desk. Say that again.
I can't wait.
Listen, oh my Jesus, that might have to be a Your Healthy Java After Dark. And then with Dr. Lambert, and I actually, let me say publicly, I owe Dr. Lambert. Listen,
Dean Lambert?
Dean Lambert is ready to
I love him.
and talk about COVID, the vaccination in the Black community. And so I need to follow up with him because we're going to do something away from this time frame on that. But it just goes to the staff and the wonderful folks there that are at MGH that are committed, that are, and Dr. Labrie has said this before, that are in the system and helping inform and then in change and address some of the inequities that we know historically have been a part of the medical industry. Look at these two folks here and take confidence in the fact that change is happening and even more change is going to come. So thank both of you so much for being with us today, and we'll be in touch.
Sounds great. Thank you. Bye, everyone.
Take care. Thank you.
Folks, that was one of our most amazing Your Healthy Java sessions with Dr. Alabre and Dr. Qureshi. Amazing, amazing. I'm going to get ready to wrap up. Just a couple of announcements. Please remember, I think actually, no, I don't have any major ones. Tomorrow and Thursday, tomorrow's the, I don't think I have anybody here on the 18th and 19th. I will say on Thursday at about maybe 10:30, 11. I don't have the exact time yet. Please plan on tuning in. I will be going live at an event. I was asked not to share the details yet, but plan on tuning in on Thursday, the 19th at about 10:30 or 11. I don't have the exact details. But yeah, it's something that you guys will want to see. It has something to do a little bit with government. So plan on tuning in on Thursday at about 10:30, 11. Tasha, thank you so much. Good to see you in the room. Good to see you. And thank you for sharing it. And the others that shared it as well. So yes, tomorrow we need to know. Probably going to do a discussion and still, because I'm still not aware if there's a plan around, violence. Memorial Day is about 2 weeks out. And we know that, I'm going to leave that there. I think that is it for me. We will see you guys tomorrow at 9 a.m. Have a wonderful day. Was it yesterday? Oh, Java on the waterfront. I talked to someone else from the team yesterday, and not only are we doing that on June 23rd, but there's going to be there. Yeah. Just remember June 23rd, right after work, plan on getting your happy selves down to the Seaport District to come for the Java Cafe on the waterfront on June 23rd, right after work at about 5:36. But we'll have more information coming out about that. All right, folks, that's it from me this morning. Thank you all for tuning in, and we will see you tomorrow morning at 9 a.m. for We Need to Know Wednesdays here in the Java Cafe with yours truly, James Jimmy Hills, not Java. Y'all know some people out there when they say, hey, what's up, Java? I'm like, how y'all doing? But I'm out of here. See you guys tomorrow morning. Peace.